Good evening, everybody. My name is Riaz Shah. I'm a medical oncologist in Kent, and it gives me great pleasure to introduce and chair you through today's webinar. This is a BTOG webinar, and in the next hour, we're going to be doing a deep dive update on mesothelioma. So a few basic housekeeping issues before we get started. I want to officially and formally thank the sponsors of BTOG. It's important to reiterate that they have absolutely no role in the planning, content, or delivery of anything you will hear today. BTOG is an excellent organization, and I want to signpost you to the executive team and the excellent website that has a wealth of information, including for members the ability to look at previous presentations, and I would implore all those in the audience who are involved in a UK delivery of lung cancer services to seriously consider joining this excellent organization. There are a multitude of webinars, a journal club for juniors, the annual meeting, and now the summer meeting that we're looking forward to in early July. A bit of housekeeping. You have a Q&A button at the bottom. You can send questions. We're going to do 3 presentations. Put forward your questions. Don't be shy, and we will moderate a discussion at the end. There will be a feedback form, which we will email to you, and you'll get a certificate of attendance if you submit that at the end, and you can get some CPD points for attending today's event. So we've got 3 excellent speakers lined up. The first speaker is going to be Miss Sarah Tenkoni. She's a consultant thoracic surgeon in Sheffield, one of the MARS 2 centres, and she's going to give us an outline on the role of surgery. Dr. Crispin Hiley, who's a consultant clinical oncologist at UCLH and UCL, is going to talk about radiotherapy. So we've got a speaker from one of the key mesothelioma surgical centres of the UK, a speaker from one of the key radiotherapy centres in the UK who've recently got a proton machine, and my colleague and great friend, Professor Sanjay Popat, our chairman, and a key opinion leader in the systemic delivery of treatments for this disease. So we're going to hear from each of them, 15 minutes each, hopefully, and then have a Q&A session at the end. And we hope, all being well, to close this meeting at 18:30. So without further ado, I'm going to hand over to Miss Tenkoni.
Hello, thank you so much, Riaz, for having me. It's a great pleasure to be here. I'll try in 50 minutes to condensate all the potential roles that surgery has in mesothelioma. And they do vary quite a lot. They can help just to improve patient symptoms, supporting the important role of the respiratory physician in the diagnosis of this disease, for example. They can have a radical intent when we aim to remove most of the disease. And they can also work together with chemo and radiotherapy and maybe something else in trying to improve patient survival. And then I think, well, as you said, with my colleagues, John Edwards and Laura Sochi, we've been one of the centres for surgery for the MARS 2 trial. We've been screening, we've been consenting, we've been operating on patient, and now we're all waiting to see what's going to happen, what the results for the MARS 2 trial will be. So the different roles, let's start from the easiest one. As I said, the standard really to diagnose mesothelioma could be just a medical thoracoscopy or a CT guided biopsy, ultrasound biopsy, but sometimes you need bigger samples. Sometimes the patient hasn't got enough fluid, or the pleura is not that thickened. So they can ask for help. So patient can have a VATS, and VATS is helpful to obtain bigger biopsies, and also during the same procedure we can do offer pleurodesis or place an IPC when needed, and I'll explain when. So this is an example. On the left you see mesothelioma, the tumor is in yellow, and you see your lung is trapped. We have drained all the fluid, but the lung is not coming up. So what we can do on the right, we can place an indwelling pleural catheter, which obviously can be used ambulatory by the district nurses to evacuate the fluid when it reaccumulates, and it helps the patient breathe better. I know this can be done, as I said, even by the respiratory physician, but there are some cases in which a general anesthetic, a short anesthetic might be a bit more comfortable for the patients. There are other cases in which the meso maybe is a little bit earlier. So you see the disease burden here, the yellow bit is not as thick as before. So when we finish to take our biopsy and the anesthetist reinflate the lungs, it actually comes out nicely. So what we can do is spray some talc inside the chest. And obviously by keeping the drain on suction for about 48 hours, we keep the visceral and the parietal pleural together, and we try to achieve pleurodesis, again, to improve patient symptoms. There has been the meso-VAT study, as you know, which wanted to compare a VATS debridement, so an operation, a palliative operation, which we try and remove by VATS, so minimal invasive as much as possible of the cancer, compared to a slightly less aggressive approach, which was just drainage and talc pleurodesis. Well, there was great hope about the role of VATS in this, but to be fair, it hasn't showed any advantage in terms of survival. The patient tend to stay in trach a bit longer, 7 days against 2. So really, it seems that there's no indication at the minute to offer VATS or pleurectomy or decortication to these patients, at least not when they can get away with the drain and some talc, for example, when the lung re-expands well. However, at 6 months, it appears that the patient who did have the PD done and the VATS report a slightly better quality of life. There is an important concept that's been introduced in 2012 about surgery for mesothelioma, and it's the concept of macroscopic complete resection. So if we go in with a radical intent, we need to aim to remove all the visible disease. That means that we accept that whatever operation for mesothelioma will give an R1 result at best, but we need to be able to achieve that macroscopic complete resection. So the big discussion among the surgeons over the past probably 25 years has been what operation is best. And there are two that are currently recognized in trying to achieve this kind of result. One is called extrapleural pneumonectomy. Again, on the left, you've got your tumor in yellow. On the right, you've got the results of the operation. The parietal pleural is gone, the visceral pleural is gone, the lung is gone, the diaphragm is gone, and the ipsilateral part of the pericardium is also gone. And then obviously they need reconstructing, so we put a patch on where the pericardium was, and we put a patch on the diaphragm. This way, obviously, we do remove all the visible tumor, but we take away the lung as well. There is another way, another operation, which is the favored one at the moment in the UK. It's the one that was performed during the master trial, and it's an operation that tried to save the lung for the patient. So, as again, you see on the left, the tumor as it was at the beginning, and then on the right, you see the visceral, parietal, pericardium, and diaphragm have been removed and replaced with a patch, but the lung is still in place. The advantage in this is that by releasing that cortex on top of the lung and leaving the lung there as well, obviously, we believe that we can help the patient maintain some of his respiratory function. Obviously, the diaphragm is not going to work, so we need to tell this patient it will take a little while for them to learn to breathe just with the rest of the respiratory muscle, so they learn to breathe differently, but in the end, they've still got their lung. This is just a very brief overview of what the end results of a radical pleurectomy decortication will look like. On the left down here, the one that doesn't move, the white one, is the patch on the pericardium, and then on slightly farther down, the one that moves is the patch on the pericardium, so on the heart, and then in a minute you will see the lung re-expand, and obviously there's a drain. In terms of current trials, unfortunately, I haven't got many results to show you today, but I thought I'll mention these two. And in fact, I will start from the bottom one, which is the SMART trial. It's not a randomized trial. It was a phase 2 observational study. They complete the enrollment though. They enrolled 96 patients and they randomized them to 2 different groups to try and establish the better timing for multimodality treatment, which in this case involved extrapleural pneumonectomy, so the whole lung out, and CISPAN. And then only in case of biopsy-proven positive lymph node, the patient were also given radiotherapy. So basically the primary outcome was feasibility, and they said that both ways, to be fair, were I'm so sorry. The previous one, the primary outcome was successful completion of treatment, and the secondary outcomes were local regional failure-free survival, overall survival, and treatment side effects. The enrollment has been completed, as I said, but the follow-up is still ongoing. At least this is what they reported on the 1st of April. So hopefully by the end of next year, because the primary outcome follow-up was only 6 months, we will know whether it's best to do chemotherapy first or surgery up front. The second one instead is a big study from the north of America, in which they basically give to all patients a 5-day course of radiotherapy, 25 gray, and then they perform extrapleural pneumonectomy within 7 days, on an average on day 5, and then only in patients with node positive proven disease, they added chemotherapy. And this one, again, has been completed. It wasn't a randomized study. And you can see that it was feasible because the mortality was very similar to the one reported in other studies. They did have some grade 3 and 4 events, and they said they need to do something to try and control that. But overall, the cumulative incidence of distant recurrence was 62 patients in 5 years, which is just about 70%. And again, it's similar to what was reported earlier. There is something else that was in fashion in the past, has gone a little bit down, but this original research was published just in February this year. I think is a very good reading, and actually asked the question on whether intracavitary chemotherapy performed during the surgery should be back in vogue. So basically, we know that using hyperthermic chemotherapy in the peritoneum has improved survival in some disseminated cancers, but can it work for mesothelioma? So there was a systematic review of 15 prospective studies, which included nearly 600 patients. Most of them had APD, so pleurectomy decortication as an operation, but some of them at APP, especially the older one, and they were all followed by hyperthermic intrathoracic chemotherapy. The chemotherapy was mainly cisplatin with some variability in, I think, 5 studies, and they did show a low mortality when compared to control groups. The main complications were atrial fibrillation and AKI. However, all patients underwent hydration protocols and nephroprotective agents were used. So this is something that, again, we can work on. The better results were with patients who received at least 175 milligrams per meter square of cisplatin, but again, the dose can vary. And so the author's conclusion is that HITEC seems to be safe. They should be considered in addition to macroscopic complete resection surgery, but obviously they advocate for randomized controlled trials. However, the ASCO has already introduced this, recommending the use in very selected centers. And it's something that probably we could start thinking about as well. Now we come to MARS-2. What's happening with MARS-2? As you know, the enrollment is finished. We have recruited ahead of schedule for most of the time. Obviously, then we had to slow down a bit because of COVID, but we only stopped recruiting for a few months. So we're back on track. 335 patients randomized. Probably the follow-up will have to be extended a little bit. So that was the original plan, January 2023 for the final report. That probably will be delayed slightly. So in the meantime, what can we do? I did a mini survey just for the purpose of this presentation in the 5 surgical MARS centres. As you see, there's 2 in London, it's Glasgow, Leicester and Sheffield. All the surgeons there, and this is a conversation obviously we had at the end of randomisation, are still offering surgery. What to do, which protocol to use. There's some variation there. Some centres carry on with the MARS-2 protocol. Some centres went back to upfront surgery for very selected patients with early disease, epithelioid subtype and node negative. So also the inclusion criteria can vary because, as you know, the one for MAS2 were quite wide. They seem to have been narrowed in all the centres at this stage. But what I found quite interesting is to make sure that you pick the very early disease that you routinely stage in the mediastinum. And interestingly, a couple of centres have already started to use a PET scan to define the actual stage. So what can happen in the future? I think we have obviously two possibilities. MAS1 is negative. So the hypothesis that we can add 30% of survival with the surgery compared to chemotherapy alone is null. Well, again, probably the inclusion criteria will be questioned because they are really wide. They included basically all subtypes with very, very little limit in terms of age. So we will need to do some subgroup analysis to pick up the best actors. And obviously the treatment protocol can be questions and will be questions because we still don't know whether induction chemotherapy is the right thing to do, plus the patient had 2 cycles of induction chemo, while normally you will probably have 3. So it will raise a lot of questions. If it is positive instead, well, probably the number of questions won't be any smaller, because are we going to offer then surgery as part of the treatment for all patients, or do we still need to identify the best actors? Also, what's going to happen in terms of delivering of mesosurgery? We can obviously roll out surgery for everybody with only 5 centres, so we'll need more centres, we need to train more surgeons. And will the MDT be able to discuss and make this decision in district generals like it happens for lung cancer at the minute, or do we need to centralize everything and keep some few very busy meso MDT with specialist surgeons in? And obviously there's a massive elephant in this room because there's still new things coming. So in the future, are we going to plan mastery regardless of the results, and what we're going to include in it? There's immunotherapy, obviously. I think that's the biggest elephant that we've got in the room, and hopefully we'll hear a little bit more later from Sanjay about that. Are we going to include radiotherapy? And again, Dr. Hartley is going to tell us something about that. And there are studies as well that have already included it. And then also, as I mentioned, maybe hyperthermic chemotherapy could play a role in selected centres. Thank you very much.
Thank you very much, Sarah. That was brilliant. Can I just remind the audience to use the Q&A button to ask any questions? They'll come on a stream and we'll try and go through them at the end of the talk. I'm now going to move on to my colleague, Dr. Crispin Hiley from UCLH UCL.
Hi there. So thanks very much for inviting me to participate in this mesothelioma essential update. My name is Crispin Hiley. I'm a consultant clinical oncologist at UCL and UCLH, and I'm going to talk about the evidence base for radiotherapy. So just a very brief bit of background. So nearly 7,000 patients were diagnosed with pleural mesothelioma in the UK in the last Royal College of Physicians audit period, which was 2016 to 2018. And from that audit, only about 15% of patients actually receive radiotherapy in the UK, and that is generally palliative radiotherapy. So 20 Gray in 5 fractions or 8 Gray in a single fraction, which are standard palliative doses for symptoms, predominantly pain. And so from that audit, the recommendation obviously is that palliative radiotherapy should be considered for symptom control, including localized pain in malignant pleural mesothelioma, where the pain distribution matches the underlying areas of disease. But as you can see, obviously, from the outcome data, that outcomes are poor, and we need to think about how we can use all our treatment, surgery, radiotherapy, systemic treatments to improve outcomes for patients. So I wanted to talk to you a little bit about sort of radiation sensitivity of mesothelioma. And it's classically being considered a radiation-resistant tumor. But actually, if you look at what the preclinical evidence is for this, that's actually not the case. There's not much data out there, but a lot of the older data suggests that it's probably of a similar radiosensitivity to non-small cell lung cancer. And this is a nice paper from a colleague of mine in the US, Mohammed Abazid, where he took 250 different cell lines from different tumor types and irradiated them. And really, just for simplicity, if you look at the integrated survival D, so the y-axis, the higher the number towards 7, the more resistant that tumor is, and the lower the number towards 0, the more sensitive it is. And you can see there's obviously a breadth of radiosensitivity for different cell lines from different tumor types, and we probably agree with a lot of the things here. High-grade gliomas being quite radiation resistant. And although it's not on the actual figure that was in the paper, I went back and looked at some of the supplementary data and plotted that here just so we can all see. These are the 7 cell lines that were included that were mesothelioma cell lines, and you can see there's a similar distribution of radiation sensitivity, and actually when you look at the median radiation sensitivity, it's very similar to the overall median of all the cell lines. So I think it's likely that genomics and the tumor microenvironment defines radiosensitivity and not histology specifically. I think the real problem for mesothelioma in terms of radiation treatment is the tumor volume, and how difficult it is to sort of irradiate all of that volume. Next slide, please. So what is the evidence? What evidence is there? So I'm going to talk to you about prophylactic intervention site radiotherapy, or PORT. I'll talk to you about palliative radiotherapy, and I'm also going to talk to you about radical hemithoracic radiotherapy, both in the post-extended pleurectomy decortication setting, but also in the radical setting for patients who don't have surgery. And that's not something that we do commonly in the UK. So PORTS, prophylactic intervention site radiotherapy. So this is something I did commonly when I was training. So 21 gray in 3 fractions using an electron field to reduce the incidence of procedure tract metastasis, or PTM, after patients have had a biopsy. And that was something we did commonly until the SMART trial was published. So this is a UK-led study where patients had immediate or deferred PORT, over 200 patients. And the primary endpoint was the incidence of PTM within 12 months. And the intention to treat analysis showed a numerical but not a statistically significant reduction in PTMs. And you can see here the odds ratio was 0.51, but it crosses 1, and also the p-value was not significant. Next slide, please. So you can see here that, again, this is from the paper. Again, there is a suggestion of a numerical difference, but actually a subsequent meta-analysis was also published that included 5 similar studies, which all confirmed the lack of benefit. So this isn't something that we do now routinely in the UK. So palliative radiotherapy. So this, I think, can be helpful for patients with symptomatic disease. Again, UK-led evidence base. So Systems 1, or Systems at the time, was the original study published in 2015. This was a phase 2 study of 40 patients, 20 gray in 5 fractions, so a very standard palliative dose. And the endpoint really was clinically meaningful improvement in pain at 5 weeks using a commonly used pain inventory score. And they showed that this was improved in 14 of the patients. Next slide, please. So this led to the Systems 2 study. So this is led by Anthony Chalmers in Glasgow. It's a UK study. It's currently open in over 18 centres in the UK. This is a randomised study. So patients are randomised to 36 gray in 6 fractions, so a high dose hyperfractionated regime. Or the standard sort of 20 gray in 5 fractions that's currently used. The slight difference is the patients have a proper plan, so intensity modulated radiotherapy or 3D planned. And again, the endpoint is clinically meaningful improvement in pain at 5 weeks post radiotherapy. And actually, it's great to hear that this is sort of nearly completed recruitment. So we're currently at 104 out of 112 patients recruited in the UK. And again, just to show you an example of the sort of volume you're treating in this sort of circumstances, it's an example of a patient treated by a colleague of mine at UCLH, who's the principal investigator at our centre. And you can see here a patient with mesothelioma who's having an area of disease treated with radiotherapy where they have pain. And often we'll ask the patient, when they come for treatment where the pain is, we'll put external wires on the skin that we can see during the CT planning so that we can help guide us about where that radiotherapy field should be. So that's palliative radiotherapy, but I wanted to talk to you now about hemithoracic radiotherapy. So I said at the start, this is not something that we commonly do in the UK. It's a very large target volume. So this is a graphical representation on the right, courtesy of again a colleague in Italy, Marco Trevo. And if you look at the sort of the red area, that's the area that you're trying to treat with radiotherapy. So this is really quite a big volume. This is probably the sort of biggest volume we try and treat in adult patients in radiation oncology. And you're trying to treat to a high dose, so over 50 gray. And the challenge is really the close proximity of important organs at risk, or OAR. So things like the heart, the contralateral lung, spinal cord, esophagus, and you really have to balance, covering the target with radiotherapy and minimizing the dose to those organs at risk to stay within safe, acceptable levels of toxicity. So Mr. Tinconi's obviously already talked about some other studies. I'm going to talk to you specifically about hemithoracic radiotherapy following extended pleurectomy and decortication. So, and these are studies run by Andreas Rimner in the US. So the IMPRINT phase 2 study was a trial that had, again, a single arm study. An endpoint was grade 3 pneumonitis. And the schedule really was platinum-based chemotherapy, followed by surgery, followed by hemithoracic radiotherapy. And again, on the right, is an example of the dose distribution that you need to achieve really for this sort of treatment. And you can see how large it is, going right from the apex of the lung all the way down to the bottom of where the pleura it potentially can be. And again, 50.4 gray in 28 fractions using IMRT. And this requires patients to be quite fit. In this study, only 45 patients were enrolled, but only 27 patients got all the way through to receive radiotherapy. So I think this is undoubtedly a challenging treatment to deliver. But I think clearly pending the results on the Mars 2 study is something that we might need to think about more closely. So that phase 2 study led to the sort of IMPRINT phase 3 study. So this is the only sort of NRG US study in mesothelioma, so NRG LU006. And this is a randomized study. So patients, as you can see here, the eligibility criteria, they have chemotherapy first, although they have surgery first, followed by adjuvant chemotherapy, and then they're randomized to radiotherapy or no radiotherapy. And the primary endpoint is overall survival. They recognize here that the radiotherapy is challenging, so there's central review of all those radiotherapy plans, and the target recruitment is 150 patients. Note here that they do allow things to be the other way around. They allow neoadjuvant chemotherapy and followed by surgery, and they also allow proton therapy to be the radiotherapy modality of choice. And I'll speak about that a little later. So what about in the context of without surgery, patients who have a biopsy only? So this is there was a study published by Marco Trevo in the Red Journal last year. Really nice study. So this was a single center, but a randomized phase 3 study of over 100 patients using a radiotherapy modality called tomotherapy, which is something we don't have much in the UK anymore. It has some benefits in that it allows you to treat sort of relatively long volumes, and obviously the whole hemithorax is quite a long volume for radiotherapy. So patients had 50 gray in 25 fractions with a boost to 60 gray to any residual tumor. and that was defined using a PET scan. And actually, as you can see here from the Kaplan-Meier curves on the right, there was quite a significant improvement in overall survival compared to palliative radiotherapy alone, and obviously a significant improvement in local regional recurrence at 1 year. However, what's the problem is that even with this overall survival benefit, there was still quite a significant grade 3 to grade 5 event rate in this study. So obviously, unfortunately, patients died following treatment. And also a significant, very high burden of grade 2 toxicities, which may well have a significant impact on quality of life. So what are the alternatives? So Riaz kindly mentioned about proton therapy. So there are some dosimetric benefits for proton therapy to allow sparing of organs at risk. On the right is the classic dose distribution curves for standard photon beams, so conventional radiotherapy, as well as sort of proton beams and how we use proton beams to create modified spread out Bragg peaks, so the blue line. And what this really means, perhaps you can see, is that you get a less entry dose with protons and significantly less exit dose compared to photons. And this allows you to spare organs at risk if they're in close proximity, particularly things like the contralateral lung and the heart, which may have a big impact on toxicity and outcome. This improvement in dose distribution can also make it easier to escalate the dose to the GTV, to the gross, so any residual tumor there. So, you might not be able to do that with photons or conventional radiotherapy, but you could potentially do that with protons. And there's several planning studies have been published, and several state centers in the US have published sort of single center experiences where they've used protons in this context. But as you know, we've now got 2 proton centers in the UK, one at the Christie and one at UCLH. And there's some evidence to suggest that if we're doing this sort of large radical hemithoracic radiotherapy fields, that we should be using proton therapy. So there's a couple of consensus statements that have been published from experts in the field, key opinion leaders, but also ratified by the IASLC and other groups, essentially saying that there's a clear dosimetric benefit for proton therapy, and this is something that we should consider using in future. Next slide, please. So I guess this is where I'll have to, another perhaps conflict. So obviously I'm a radiation oncologist and I'm interested in using protons. And so we've submitted this study for funding to Asthma and Lung UK. We don't know what the outcome will be, but hopefully, if we're successful, this is a trial we can open and lead from the UK. So this is the trial of radical hemithoracic radiotherapy for patients with mesothelioma. Primary endpoint is overall survival, looking to recruit from over 20 centres in the UK. So be looking for people to participate. 148 patients, and I've helped set up this study in combination with other colleagues across the UK, Paul Shaw in Cardiff and David Wolfe in Manchester. And patients will have initial systemically administered chemotherapy if it's appropriate for them, and then be randomised to either the standard of care, maybe observation, or the experimental arm, which is proton beam therapy, to a dose of 50 gray and 25 fractions of hemithorax with a boost to 60s. So again, the same fractionation used in the Marco Trovo single center phase 3 study, but just using protons. Next slide, please. And I just wanted to show an example quickly, really, about about protons. There's a learning curve with using protons, and so in anticipation that we may get funding for this study, we've been working on planning a few cases with protons. And you can see on the left is a proton plan, and on the right is the photon plan, so the conventional radiotherapy for the same patient. And I've set the color wash at the 20 gray mark, so that's an important constraint for lung toxicity. And you can see that certainly for the contralateral lung, for the liver, for the ipsilateral kidney, there's a significant improvement in dose distribution. And the graph at the top is what we call a dose volume histogram. And really, if you just try and take away from that for the lines that are the same color, which one is being the photons, one being protons, conventional photons being the triangles and the proton plan being the squares, that actually the lines with squares are much lower, showing that actually we get significantly much better dose distribution to the kidneys, the heart, the lung, and the liver. And that's important, not just from toxicity, but also important in terms of thinking about what subsequent treatments those patients might need, and preserving organ function. Next slide, please. So in summary, there's a significant unmet need for patients with mesothelioma, which is obviously why we're all here. There's still a big role for radiotherapy in tandem with surgery and systemic treatment. Palliative radiotherapy offers effective symptom control, and there is evidence to show improved overall survival seen with conventional photon hemithoracic radiotherapy, but this does come with significant toxicity, and perhaps protons may be better, but we need randomized evidence for that. And thanks very much for your attention.
Brilliant. Thank you very much, Crispin. I now want to move to Professor Sanjay Popat, who's going to update us on the latest in systemic therapies in mesothelioma.
Great. Thank you, Riaz. So these are my disclosures. I'm going to try and keep this quick. So there's a few things that you need to know about updates in mesothelioma. The first is there's been a big reorganization of pathology, and this may or may not impact on your decision making in terms of how you manage your patients, of course, which will involve drug therapy. So 4 main outcomes of the new WHO 2021 classification update, which are summarized in this beautiful summary in the JTO published recently. Number 1, well-differentiated papillary mesothelioma is now called a mesothelial tumor. It's a low-grade tumor, probably needs to be resected, or in an elderly patient untreated, certainly doesn't need chemotherapy, and the role of checkpoint inhibitors is unknown. Number 2, mesothelioma in situ has now been defined as a pathological diagnosis, probably should be treated with surgery, may need chemotherapy, unsure whether immunotherapy has a role to play in this disease, probably does. Number 3, epithelioid mesothelioma should now be graded high and low grade by the nuclear atypia that's identified by the pathologist. And this will probably help determine prognosis and will probably help determine your systemic therapy, because you're going to get more out of your high-grade tumors with chemotherapy than your low-grade tumors, and you're probably going to get more out of your low-grade tumors with immunotherapy than your high-grade tumors. Needs to be tested, but if you don't collect the data, you'll never find out. Fourth thing, the phrasing and recommendations on how you classify a non-epithelioid tumor has changed. So it's a little bit easier to call it a biphasic tumor now. That may be impactful depending on where we're going with immunotherapy usage. So what are we doing in the first line setting for patients in terms of our systemic therapy options? So we have now the updated 2022 ESMO mesothelioma clinical practice guidelines. And this says that if you're not thinking about surgery for your patient for a variety of reasons, then you should really be thinking about either chemotherapy with cisplatin pemetrexed or carboplatin pemetrexed, or nivolumab, ipilimumab, and both have got high grading. I would personally suggest you think about doublet immunotherapy as the preferred modality of choice. And this is based on the Checkmate 743 trial, which is an international multi-center randomized phase 3 trial, in which patients all with mesothelioma that was determined to be unresectable randomized either the standard chemotherapy, cisplatin or carboplatin, with pemetrexed for a total of 6 cycles, or nivolumab with low-dose ipilimumab every 6 weeks, that's 1 milligram per kilogram, up to a total of 2 years. Now, all types of mesothelioma were eligible, and the primary endpoint of the study was overall survival. And you can see that the primary endpoint was met with a consistent performance of immunotherapy with a median progression-free median overall survival of 18.1 months, which is consistent with epithelioid and non-epithelioid subtypes. All you can see is that chemotherapy has modest efficacy in non-epithelioids, making the difference really quite important. This study was not designed to tell you which subtype you can give, because it's not powered to give you a benefit by subtype. What you can see when you look at the quality of life data is that the quality of life measured by the LCSS mesothelioma ABSI subscale continues to improve with immunotherapy in the non-epithelioid, and it stays pretty flat in the non-epithelioid for chemotherapy. However, in the epithelioid, the quality of life actually tends toward deterioration with chemotherapy, where it clearly improves with immunotherapy. And for me, this is one of the most underlying important facets for why checkpoint inhibitors should now be considered standard of care over chemotherapy. What else have we learned from Checkmate 743? Well, patients could have carbo or cisplatin. The overall survival is exactly the same. So from my viewpoint, why on earth would you now give cisplatin to your patients with mesothelioma? The other thing that we've learned is that in some patients, progression-free survival was slightly inferior for the first 7 months for checkpoint inhibitors than it was for chemotherapy. Now, this has an important role if you're going to think about using that as induction prior to surgery, which you shouldn't be, because the guidelines all recommend chemotherapy around surgery. But clearly, what we need to think about is, who are this group of patients? Are these the symptomatic patients? Does it really matter if they're clinically benefiting? Certainly, the long-term progression-free survival is really quite important with this group of patients. We've now had the 3-year survival update, and when you look at progression-free survival at the 3-year time point, it's 14.1 months that are progression-free with checkpoint inhibitors compared to 0 patients with chemotherapy. And we are looking forward to presenting the 4-year data in due course. What about side effects? Yes, there are more side effects and adverse events with immunotherapy than with chemotherapy. So you have to think about patient selection appropriately and be able to manage the adverse events appropriately. And I think all oncologists that use these drugs are aware of that. But if your patients do get toxicities, you need not panic, because when we went back to look at the adverse event outcomes, those patients that developed treatment-related adverse events leading to discontinuation actually had a better overall survival than those that didn't. And we've seen this across different tumor types. So what do you do after Nivo-Ipi? Well, you'd probably then want to go back to your old-fashioned platinum pemetrexed, but the guidelines have now incorporated maintenance gemcitabine as an option, and this is on the basis of the NVAL-19 study, which demonstrated giving maintenance gemcitabine after completion of platinum doublet chemotherapy leads to PFS benefit, particularly in the epithelioid group, not the biphasic or sarcomatoid group, but no overall survival benefit. So this may well be suitable for some patients, not all patients, but I would certainly consider it in patients completing 6 cycles of chemotherapy. So where are we going with frontline treatments with mesothelioma outside the operable space? Well, there are 3 big trials which are going to report either at the end of this year or more likely at the end of next year. These are the French-Canadian NCTC trial, which has combined chemotherapy with single-agent immunotherapy, pembrolizumab. There's the DREAMER trial, which is recruiting a bit slower, combining chemotherapy with single-agent immunotherapy durvalumab. And there's the BEAT-MESO trial, which has now completed accrual, which is combining chemotherapy with immunotherapy together with bevacizumab with a dual agent. Now, will these trials improve the PFS? Probably yes. Will they be able to beat doublet immunotherapy? Who knows? And I guess this is the key issue. We certainly know that double immunotherapy is better than single immunotherapy, probably in the relapse setting. So will we see this in the frontline setting? Well, this is interesting, and let's see where we go. Other trials that we'll be reporting, hopefully sometime later this year, maybe early next year, will be Peter Schroeder's ATOMIC study. This, if you remember, randomized biphasic sarcomatoid patients with ASS1, which was low to either chemotherapy with pemetrexed and cisplatin. Well, we know how that's going to perform from the Checkmate 743 arm, or that together with ADI-PEG 20. Let's see what the results are and if they compare anyway to Checkmate 743. Post-operatively, Sarah will be delighted to know our Italian colleagues are looking at the role of immunotherapy in a large trial. This is the ATESO-MESO trial, which is being run by Italian colleagues. Patients have upfront surgery. They then have 4 cycles of adjuvant chemotherapy, and then at the end of the chemotherapy, if fit and well, are randomized to either placebo for a year or adjuvant immunotherapy for a year. Primary endpoint is disease-free survival, and it's really a very important study that we need to get data for. Now, our patients will sadly probably relapse at some point through all of these options, and we're then thinking about second-line treatment options. Guidelines will recommend single-agent chemotherapy, and if they've not experienced it before, they could have single-agent immunotherapy, either nivolumab or pembrolizumab. Currently, we have nivolumab available. I'm afraid this has not been formatted according to my specifications, so a note to the tech team to get it right next time, please. So what this study is, what this slide is meant to show is that the performance of immune checkpoint inhibitor, whether you're giving pembrolizumab or nivolumab, is exactly the same. It doesn't really matter. We have nivolumab available, but the bottom line is the performance of checkpoint inhibitors are really not very good in the second line setting. So don't wait to the second line setting to give you a checkpoint inhibitor, give it up front. And we see exactly the same in lung cancer, so no surprise there. What about experimental treatments coming through? So there are a number of experimental treatments coming through. We wrote this paper with Tim Yap and Dean Fennell a while ago, talking about stratified drug therapy for mesothelioma, and we're starting to see this occurring. Dean has been leading the MIST study in Leicester, Newcastle, and a few other places, and most of the trial arms are closed. He's recruited patients to rucaparib with BAP1 or BRCA loss and demonstrated a modest benefit in those patients. He's proposing a trial called NERO, where patients in the relapsed setting are randomized either to single agent, the frontline setting are randomized to either chemo or immunotherapy, or in the experimental arm, chemo followed by niraparib, which is reasonable for this group. He's looked at the CDKN2A loss group of patients, treated them with abemaciclib, demonstrated some evidence of benefit. He's presenting the VEGF PD-L1 data at ASCO later this year, and he will be recruiting to a PARP inhibitor PD-1 combination arm in patients with a DNA damage repair molecular profile. A few other interesting trials going on. The Spanish have a trial of bintrafusp alpha, which is a fusion protein of PD-1 and TGF-beta, which is ongoing, and there is a phase 1 trial ongoing in various places of the PRMT5 inhibitor for patients with CDKN2A deleted cancers. MTAP testing is now on the National Cancer Test Directory for mesothelioma, so make sure you can get your patients' profiles. And there's a phase 1 trial ongoing of patients with NF2 mutation or loss of the Hippo pathway inhibitor from Novartis, IAG 933. So this does remind me that NTRK testing is available for your patients, so do make sure you get your patients NTRK tested, and you'll probably get the rest of the NGS profile thrown in for free if your GLH is feeling lucky. And with that, I'll thank you and hand back to our host for the rest of the meeting.
Brilliant. Thank you very much, Sanjay. That was excellent. So if all our speakers could unmute and switch their cameras back on, we're going to have a little discussion in the final sort of 10, 11 minutes that are left. I want to thank you all. I think the audience should appreciate just how leading the UK is in the international mesothelioma research market. Here we have had a series of 3 talks. We're leading in surgical trials, radiotherapy trials, and systemic chemo trials, one of the lead recruiters to beat meso. So fantastic effort to everybody. So I'm going to go through a few questions. So first question to Sarah, from Professor Lim, no less. If the MARS-2 trial is negative, what surgical treatment options need to be evaluated next?
Well, that is a very good question. I think we need to be creative there. I don't think we can make up a different operation. What was it? We evaluated the VATS-PD, we evaluated EPP, we evaluated EPD as well. I think it would be more which combination surgery needs to be put into as part of a multimodality treatment to make it more effective. But yes, I think the problem is the time is the clock is ticking, and obviously our patients are becoming less and less well. So one of the reasons to move from an EPP into an EPD as approach, especially in the UK, is exactly that. The patient are getting older and unfit. So I think the more we go on, probably the less aggressive we need to be. In terms of, we will be able to be really in terms of surgical approach.
Thank you. One of the things I wanted to ask you, Sarah, was about these IPCs. So in your center, when an IPC is inserted, how often are they drained in the community? There seems to be a lot of sort of differences in practice. And is there a risk if these IPCs stay in too long that the patient may develop an empyema or some other complication?
Yes, there is obviously for every long-term foreign body, there is always a risk of infections, no doubt about that. Usually, most of the IPC, well, we've got a brilliant physician, they are inserted by the respiratory physician. When we put them just as an additional thing at the end of the procedure of the biopsy, they then are managed by the district nurses quite well. It depends the amount of fluid they are draining, but it seems like with time they tend to drain less and less. So initially mine is 3 times a week, and then it's twice a week. And again, because every time that you do whatever maneuver on that, there is a risk of infection. You should really try and minimize, and it should be more patient-led. So when the patient feels, sometimes the patient themselves learn how to do it. So when they feel that the breathing is getting worse, they know how to drain it in order to get some relief.
And then a few questions for Crispin. Crispin, 50 grain, 25 fractions of proton therapy. If you're a patient walking into UCL and you're about to have one of these 25 fractions, how long are you going to be on the machine for having that treatment?
Yeah, it's a good question. So I think obviously as we start treating patients, on these proton beams, the treatment times have been longer. As we're getting more comfortable treating patients on the proton beam, they're shorter. But you're going to be in the room having treatment for half an hour. I mean, the beam on time will be much significantly less than that. But as I say to all patients, you've got to think about sort of half an hour, 40 minutes to get in the room, lie on the couch, make sure that you're sort of in exactly the right position. And then all the patient has to do is lie still, and they're supported by the radiographers. Any problems, they'll come in and help them. And obviously when the radiotherapy is going in, they don't feel anything. It's not painful. It's not not radioactive afterwards. I think it's something that would certainly be tolerable by patients.
And then one of the things you mentioned, the port site radiotherapy, prophylactic radiotherapy. So we know that treating with radiotherapy helps. One of the things that happens is patients don't often report the lumps as they appear. So the first time you hear of it and it gets mentioned in a clinic room and you expose the patient's chest, you see quite a frightening mass. Would I be right in thinking that these things, when picked up at a smaller size, are more palliatable than if they're larger, and that maybe should we be training patients to report these things earlier, to look out for them and specifically report them? Or doesn't it make a difference?
No, I think that's a fair comment. I don't think there's any evidence to prove that, but I think we would take that from all situations where patients have fungating things that break through the skin. The earlier you can treat it, the better. And we know that for breast cancer lesions, other tumor types. So I think certainly if patients have clearly things that the pain or lumps around a procedure tract, they should let their oncologist know about it.
Excellent. Thank you very much. Now, a few questions for Sanjay. Sanjay, I got the impression that you were saying combination doublet immunotherapy, nivolumab and ipilimumab, is first-line standard of care systemic treatment for mesothelioma. You showed us those curves showing really quite substantial benefit in non-epithelioid tumors, somewhat less obvious in epithelioid. You didn't mention PD-L1. Do you think there's any role for PD-L1 testing in mesothelioma? Does it have any utility in clinical decision making? And do we even know how to read it, test it, and have reliable results?
I'll be very clear here. No, there is no role whatsoever for PD-L1 testing in mesothelioma.
That's fairly definitive. Tell me about BAP1 testing. What is the role? Because increasingly people are getting reports with BAP1 and haven't got a real sense of how to interpret that. What does it mean? Why is it being done?
Yeah, BAP1 loss is seen in up to 60% of mesotheliomas and is usually a somatic mutation. So it occurs in their cancer. And BAP1 loss can help a pathologist differentiate between atypical mesothelial proliferation and an invasive mesothelioma. when they do not necessarily see invasion of the basement membrane, which is usually required for a pathologist to make a diagnosis of mesothelioma. So that's basically why you're seeing it. It results in altered DNA replication, and there are trials ongoing looking at it as a drug target. About 2% of mesothelioma patients have germline mutations in BAP1 that is not routinely commissioned to be tested for in the germline. It should be. Me and others are working in the background to try and make this the case, because these patients have inherited family syndromes which predispose to ocular melanomas, renal tumors, etc. So when you see it on your path report, it's somatic, it's not really germline, and it helps the pathologist makes the diagnosis.
Thank you very much. Now, we've had a few questions about, well, when is doublet immunotherapy going to be available in our clinics? I don't know if you've got any news on that or any sense of where we are with that.
It's available now. You just need to contact your BMS liaison and ask for a compassionate use supply. The NHS funding for that is still under negotiation between BMS and NICE. I have no idea where those discussions are. I, like you, hope that they resolve quickly and we have formal access. But until then, my view is that there is no other suitable treatment that patients should be getting in a frontline setting if they are trial eligible and suitable to receive this drug.
And then I suppose the next question revolves around combining all three of your skills, so surgery, radiotherapy, chemotherapy. And do we have any sense? I suspect that after Mars 2 reports, the next thing we'll be doing is scratching our heads together in a room and trying to think about a multimodality strategy. And the question is, who goes first? And do we irradiate a tumor first? Do we shrink it with chemotherapy first? Do we resect it and give adjuvant therapies first? Can I have all your thoughts on what's your sense of how we should sequence multimodality therapy, if that's where we're going to go in the next study? Sarah?
Although we are always happy to operate, for example, after pleurodesis, because any form of fibrosis is fine, it's good and makes our job easier. If radiotherapy comes in at any point, and I think that will happen at some point, as they are doing in America, we will have to go immediately after that, because if you leave it for too long, then the fibrosis will be such that the operation will be too risky. Whether chemotherapy goes before or after, I think we'll have to wait for the results of the randomized trial that is ongoing to have an idea of that.
Any thoughts on that issue, Crispin? If you're designing the next UK study and radiotherapy is going to be part of it?
I think the honest answer, Riaz, is I'm not sure, to be honest. But I think, clearly there's certain ways it could be done. I think the Mars 2 result will help in terms of surgery, about how we position, radiotherapy, a bit like the NRG-LU 006 study. In terms of the trial that I proposed with proton therapy, and now, potentially we've got, doublet immunotherapy. I think it's very reasonable to do radiotherapy up front, and on progression, patients could have, doublet immunotherapy. That means they get access to all the treatments, but both radiotherapy and chemotherapy. Alternatively, I think doublet immunotherapy, or up front, and followed by radiotherapy on progression, again, is a very reasonable thing to do. I think it will help all of us, when there's clarity from NICE about funding and availability in the UK, about how we position these things. There was a large part of my grant application was really about, what do we do if immunotherapy becomes standard of care, and how we position the trial. So I think hopefully, it's great news that we've got great surgical techniques. It's great news that we've got immunotherapy doublets. None of these things are a home run. Radiotherapy certainly isn't a home run, and I think hopefully by combining all of these things, we can really push up the sort of 3 and 5 year overall survival.
Thank you. Well, we've come to the end of our hour, so I want to thank you all for attending. I hope you found today's meeting useful. Thank BTOG, thank the sponsors, and wish you all a very pleasant evening and bank holiday weekend. Goodbye.